Imagine you are, just going about your completely normal, completely unremarkable day.
Right.
You're standing at your bathroom sink, looking in the mirror, maybe just brushing your teeth. Or you're out taking a casual stroll down the sidewalk to the grocery store with a friend. The sun is shining.
Just completely mundane stuff.
Exactly. Or perhaps you're just sitting on your couch, watching a movie, eating a piece of chocolate. The most mundane activities you can possibly think of. And then, literally without a single warning sign, your body goes into absolute crisis mode.
Total systemic rebellion.
Yeah, total rebellion. We're talking severe hives erupting across your arms and chest in seconds.
Mm-hmm.
Your throat, actively closing up so you can't pull air into your lungs.
Which is terrifying.
Oh, beyond terrifying. Your blood pressure drops so rapidly that the room starts spinning, your vision tunnels, and your legs just give out.
Mm.
Suddenly, you are in an ambulance.
Sirens blaring.
Right. The sirens are blaring, paramedics are shouting, doctors in the ER are rushing around you to stabilize your vitals. And when the dust finally settles, when you are lying in a hospital bed and you can finally take a breath again, the doctor looks at you over a clipboard and asks, honestly, the most logical question in the world. They ask, so what are you allergic to?
And this is where the nightmare really begins.
Yeah.
Because for the patients we are talking about today, the answer, even after months and months of exhaustive, terrifying medical testing, is, well, absolutely nothing that anyone can find.
Welcome to this deep dive. If you've ever wondered how much we really understand about the human body, or, if you've ever been frustrated by a medical mystery, this exploration is absolutely custom-tailored for you.
It really is.
Today's mission is to unpack a condition known as Idiopathic Anaphylaxis, or IA for short. And to do this, we've been poring over a fascinating stack of source material. We're synthesizing 3 different pieces here.
Yeah, a clinical review, some really new genetic updates, and a qualitative study.
Right. The clinical review covers how this condition is diagnosed and managed. The update looks at the absolute cutting-edge genetics being discovered right now. And maybe most importantly, I think, the deeply moving qualitative study explores the lived experience, like what it actually feels like for patients dealing with an invisible enemy day in and day out.
It's a compelling stack of research, precisely because it attacks the mystery from every possible angle, the molecular, the clinical, and the human side of things.
Exactly.
But before we get into the psychological toll or the cutting-edge genetics, we really need to establish exactly what is happening biologically during one of these attacks.
Right, the baseline stuff.
Yeah, we have to define anaphylaxis itself.
Because most people, they hear anaphylaxis and just think, really bad peanut allergy, right? But what is mechanically happening inside the body?
Well, at its core, anaphylaxis is a severe, systemic, life-threatening allergic reaction. It's driven by specific immune cells in your body called mast cells, and to a slightly lesser extent, basophils.
Okay, mast cells.
Think of mast cells as border patrol guards. They're stationed throughout your tissues, especially in places that interact with the outside world, right? Like your skin, your gut, your respiratory tract.
That makes sense.
Inside these mast cells are tiny granules, and they're filled with potent chemical mediators. The most famous one is histamine.
Which everyone has heard of because of antihistamines.
Exactly. But there's also an enzyme called tryptase in there, which is going to be very important later.
Okay, so histamine and tryptase. And usually the body releases those chemicals for a very good reason, right?
Yes, absolutely. In a normal allergic reaction, someone with a peanut allergy eats a peanut. The peanut protein binds to antibodies on the surface of the mast cell. The mast cell degranulates.
Degranulates, meaning it
essentially explodes. It dumps massive amounts of these chemicals into the surrounding tissue in the bloodstream. The histamine causes blood vessels to dilate rapidly, which drops your blood pressure, and it causes smooth muscle to contract.
And that's why your airways swell shut.
Exactly.
But the crucial word in our deep dive today is idiopathic.
Correct. In medicine, idiopathic basically means a condition arises spontaneously or, the cause is entirely unknown.
So no known trigger.
Right. So idiopathic anaphylaxis means that the mast cells have detonated, the chemical flood has occurred, the patient is in life-threatening shock, but even after the most rigorous medical investigation imaginable, no trigger can be found. No peanut, no bee sting, no new medication.
Okay, let's unpack this, because the biology here is just wild to me. If I had to visualize what is happening, I'd compare the human immune system to, a state-of-the-art high-tech home security system.
Oh, that's a good way to look at it.
You know, the kind motion sensors on every window, thermal cameras, automated locks, and usually it does its job perfectly. If a burglar kicks in the front door, the alarm blares, the deadbolts lock, the sprinklers deploy to put out a fire.
Right. That's your mast cells reacting to a genuine threat.
Exactly. But with idiopathic anaphylaxis, it's like that massive alarm system suddenly goes off at like 2 p.m. on a sunny Tuesday.
Yeah.
The sirens are screaming, the doors are locking, the sprinklers are totally ruining the living room furniture, and there is absolutely no intruder on the cameras.
Nothing.
The system is reacting with deadly force to a ghost.
And taking that security system analogy further, the danger isn't coming from the non-existent intruder. The danger is that the security system's response is so aggressive, it might actually destroy the house.
Wow.
The massive drop in blood pressure and the closing of the airway are the body's defense mechanisms gone completely rogue.
Now, you listening to this might be wondering why this matters to you, especially if you don't have this incredibly rare condition. But understanding idiopathic anaphylaxis actually unlocks a much deeper understanding of how our immune systems work as a whole.
Oh, absolutely.
It reveals the undeniable physiological link between the mind and the body. And frankly, it exposes some massive blind spots in modern healthcare. Sometimes, looking at what happens when a system inexplicably breaks down is the only way we learn how it's supposed to function in the first place.
That's a fundamental truth in medicine, really.
Yeah.
Anomalies push the boundaries of our knowledge. And, to understand the human toll of this anomaly, we first have to look at the numbers.
Right.
We need to realize why this diagnosis is such a moving target for allergists and immunologists around the world.
So let's get into the epidemiology, because the numbers in the clinical review genuinely shocked me. How common is this invisible enemy?
Well, within the realm of severe allergic reactions, it is surprisingly common. The clinical review indicates that idiopathic anaphylaxis accounts for somewhere between 30% to 60% of all anaphylaxis cases in adults.
Wait, up to 60%? Are you saying that in some places, more than half the time an adult is rushed to the ER in anaphylactic shock, the doctors ultimately just throw up their hands and say, we have no idea what caused this?
That is exactly what the data suggests. But the complication here is that this rate varies wildly on a global scale.
Okay, how so?
The sources highlight some really stark regional differences. For instance, in Taiwan, idiopathic anaphylaxis accounts for about 10 to 22% of cases.
Okay.
But in Poland, the rate is remarkably low, sitting at just 3.5%. Meanwhile, in Canada, it hovers around 10%.
That geographic variance is massive. I mean, why would someone in Poland only have a 3.5% chance of their anaphylaxis being idiopathic, while someone in another country might be looking at a 60% chance? Are human immune systems like that different based on borders?
No, it's highly unlikely to be purely genetic or biological differences across those populations. It's much more likely a reflection of diagnostic resources, reporting standards, and environmental factors.
Oh, like what's actually around them in the environment.
Right. Different regions might have vastly different endemic allergens, hidden triggers that doctors in one country know to look for, while doctors in another country might miss completely. And if a trigger is missed, the case just gets dumped into the idiopathic bucket.
That makes total sense. We're definitely going to dig into those hidden triggers in a minute. But what about the demographics? Because the sources point out a very specific trend about who is actually getting this.
Yes. It is predominantly a condition that strikes adults. It is much rarer in children, accounting for only about 10% of pediatric anaphylaxis cases.
Oh, wow. Okay.
But more specifically, across most global reports, IA appears to be significantly more common in adult women.
Is there a biological reason for that? Like, why adult women specifically?
The source material dives into this, and it points strongly toward hormonal influences. Hormones are incredibly powerful chemical messengers, right? And their fluctuations can directly impact immune cell stability.
So hormones can act as a trigger.
Exactly. When allergists are investigating these cases in adult women, they have to consider things like progesterone hypersensitivity or estrogen hypersensitivity as part of the differential diagnosis.
Wait, hypersensitivity to your own hormones? Meaning a woman's body could essentially be allergic to her own natural cycle.
It sounds like science fiction, I know, but yes. There is a recognized clinical entity called catamenial anaphylaxis. This is a severe allergic reaction that is directly, cyclically related to a woman's menstrual cycle.
That is unbelievable.
The literature also documents lactation-associated anaphylaxis. So the fluctuations of these hormones can actually destabilize the mast cells, prompting them to release their mediators without any external allergen present.
So the body's internal clock becomes the trigger. That is wild. But here's where the epidemiology gets really interesting to me. The sources highlight a fascinating trend over time. Historically, in decades past, IA was said to account for up to 59% of all anaphylaxis cases across the board.
Right, historically.
But recently, in modern literature, that number has dropped to around 35%. Did the disease itself suddenly change? Are people getting less idiopathic anaphylaxis?
Not at all. The disease hasn't changed. Our science has evolved. The epidemiology of IA is shrinking simply because our diagnostic tools are getting sharper.
We're just finding things better.
Exactly. We are discovering new, deeply hidden clinical entities that we previously didn't even know existed.
If the numbers are dropping because we're finding new, previously unknown allergies, it makes me wonder, is idiopathic anaphylaxis even a real disease? Or is it just a placeholder, like a fancy Latin term that doctors use to write "science hasn't figured your body out yet" on a medical chart?
It is entirely a placeholder. And you've hit on the core reality of this condition. Idiopathic anaphylaxis is strictly what the medical community calls a diagnosis of exclusion.
A diagnosis of exclusion.
Right. You do not get this label because a doctor finds a specific biomarker that proves you have it. You only get this diagnosis when modern medicine has aggressively exhausted every other single possibility. It is what remains when the list of known diseases is completely crossed off.
Which means the burden of proof on the patient is astronomical. Because it's a diagnosis of exclusion, patients don't just, walk into an allergy clinic, get a quick skin prick test, and go home with answers.
No, definitely not.
They have to run a grueling, terrifying medical gauntlet to prove they aren't suffering from 100 other potentially fatal things first.
The clinical pathway is incredibly demanding. Doctors refer to this as the differential diagnosis, the process of ruling out the imposters, and the sheer volume of conditions a doctor must rule out before declaring a case idiopathic is staggering.
Let's talk about those imposters. What exactly are they looking for? Because the sources break this down into several categories, starting with cardiovascular and respiratory events that mimic an allergic crash.
Yes, because if a patient arrives in the ER unconscious with no blood pressure, the immediate assumption isn't necessarily allergies.
Right. Sure, it could be a heart attack.
Exactly. The doctors must rule out cardiogenic shock. This is when the heart muscle suddenly fails and can no longer pump enough blood to sustain the body. The drop in blood pressure looks like anaphylaxis, but the mechanism is entirely different.
Got it.
They also have to rule out severe vasovagal syncope, a sudden, dramatic drop in heart rate and blood pressure triggered by the nervous system, which usually causes fainting.
Right. And they mention pulmonary embolisms, too.
Exactly. A pulmonary embolism is a blood clot that travels to the lungs and blocks an artery. It causes sudden, severe shortness of breath, chest pain, and a rapid drop in blood oxygen and blood pressure. To an ER doctor acting quickly, a patient gasping for air and going into shock from a clot looks remarkably similar to a patient whose airways are swelling shut from a mast cell degranulation.
So they have to check the heart and lungs to make sure it's not a structural failure. That's category 1. But then the sources get into the endocrine system, and this sounds like an episode of a medical drama. They're looking for tumors.
Neuroendocrine tumors, specifically. This is a crucial step in the differential diagnosis. They must rule out things like pheochromocytoma.
What?
Pheochromocytoma. It's a rare, usually benign tumor of the adrenal gland. But what it does is terrifying. It episodically dumps massive amounts of adrenaline and noradrenaline into the bloodstream.
Oh, wow.
A patient with this tumor will experience sudden explosive panic, profuse sweating, a racing heart, and skyrocketing blood pressure, followed by a crash.
Which feels exactly like an allergic reaction to the person experiencing it.
Precisely. They also look for VPOMAs, which are tumors that secrete a substance called vasoactive intestinal peptide. This causes massive sudden diarrhea, skin flushing, and dehydration.
It just sounds so overwhelming.
And they have to rule out carcinoid syndrome, where tumors secrete serotonin and other chemicals, causing severe flushing, wheezing, and blood pressure fluctuations. Even rare things like medullary thyroid cancer have to be crossed off the list.
It is deeply unsettling to think that you go into a clinic hoping for an EpiPen and the doctor says, hold on, we need to run a scan to make sure you don't have a rare neuroendocrine tumor secretly dumping adrenaline into your blood.
And the gauntlet doesn't end there.
Yeah.
They also have to explore the psychological and neurological category. They must evaluate the patient for seizures that present with autonomic features.
Autonomic features?
Yeah, most people think of a seizure as convulsions, but some seizures primarily affect the autonomic nervous system, spiking the heart rate, altering digestion, or changing the respiratory rate without the classic shaking.
Oh, so it wouldn't even look like a seizure. And they have to consider mental health conditions too, which we know can manifest physically.
Yes. They must rigorously evaluate for severe panic attacks. A severe panic attack can cause hyperventilation, a racing heart, chest tightness, and a profound, overwhelming feeling of impending doom, which, by the way, is actually a clinically recognized symptom of anaphylaxis as well.
The feeling of impending doom, that's so heavy.
They also have to consider somatic symptom disorder, or SSD, where severe psychological distress manifests as very real, very debilitating physical symptoms.
Okay, so that's ruling out all the non-allergies, the tumors, the clots, the panic attacks. But then they have to hunt for the hidden allergens, the stealthy intruders that used to be called idiopathic before science caught up with them. The sources list some incredibly bizarre, highly specific triggers that can completely masquerade as a spontaneous attack.
They do, and the most famous example in recent medical history is alpha-gal syndrome. For years, allergists were baffled by patients who would wake up in the middle of the night in full anaphylactic shock.
Because they were just sleeping.
Right. They hadn't eaten anything in hours, they were asleep in their own beds. Doctors repeatedly labeled these cases idiopathic.
Because it made no sense. You don't get a food allergy reaction 6 hours after you eat.
Exactly. The timeline violated all the basic rules of food allergies. But then, researchers discovered the mechanism. Alpha-gal is short for galactose alpha-1,3-galactose. It is a sugar molecule found in the meat of mammals, beef, pork, lamb. But humans don't naturally have an allergy to it. The allergy is triggered by the bite of a specific tick, the Lone Star tick.
May I make sure I have this straight? A tick bites you on a hike. It alters your immune system, so you suddenly develop antibodies against the specific mammalian sugar. And then what happens?
Weeks or months later, you eat a steak for dinner. The steak digests, the alpha-gal sugar enters your bloodstream, but the allergic reaction is incredibly delayed. It takes hours for the lipids carrying the sugar to reach the sensitized mast cells.
Oh, wow.
So you go to sleep, and at 2 a.m, the mast cells finally encounter the alpha-gal and detonate.
That is wild. A bug bites you, and suddenly you are violently allergic to a hamburger you ate 6 hours ago. It's no wonder doctors thought the immune system was just spontaneously exploding.
Right. It looks completely spontaneous.
But it's not just alpha-gal, right? The clinical review mentions other incredibly niche environmental triggers.
The literature specifically highlights cases that were written off as idiopathic until tenacious doctors discovered the patient had an incredibly rare, hyper-specific allergy. They mention hidden spices in restaurant food. They mention sulfites, which are used as preservatives in wine and dried fruits. They mention carmine powder.
Wait, isn't that the red dye made from crushed bugs?
Yes, cochineal bugs. It is a natural red dye used in everything from cosmetics to strawberry yogurt to red candies. If a patient has a severe allergy to carmine, tracking that down is like finding a microscopic needle in a haystack.
I can't even imagine.
The sources even mention documented cases of anaphylaxis triggered by rare animal danders, like a specific allergy to horse dander, or in one bizarre documented case, anaphylaxis triggered by a hamster bite.
A hamster bite. I picture the diagnostic process for idiopathic anaphylaxis like playing the most stressful, high-stakes game of guess who you can possibly imagine.
Pretty accurate.
The doctor is sitting across from the patient, flipping down the little faces on the board one by one. Is your trigger a rare neuroendocrine tumor? Flip. Is it an allergy to crushed red bug dye in your lipstick? Flip. Is it a delayed reaction to a tick bite you got 3 months ago? Flip. Did you get bitten by a hamster? Flip.
Right.
They have to flip down every single rare tumor, every cardiovascular anomaly, every hidden spice before they are finally left with the one blank card at the very end.
And to guide doctors through that exhausting game of elimination, there is one crucial objective biochemical test that the clinical review stresses above all others, measuring serum tryptase.
Right. If we go back to the home security analogy, tryptase is the footprint the intruder leaves behind. Explain how doctors use this test.
Well, we established earlier that when mast cells degranulate, they release histamine and tryptase. Histamine clears out of the blood very quickly, so it's hard to measure in an ER setting. But tryptase is a much larger enzyme, and it lingers in the bloodstream for several hours.
Oh, so they actually have time to find it.
Yes. Because the physical symptoms of anaphylaxis overlap so heavily with other emergencies, like a panic attack, heart attack, or an adrenaline-secreting tumor. Doctors desperately need chemical proof that a mast cell event actually took place.
So how did they get that proof?
They need 2 data points. First, they need to draw the patient's blood to measure their baseline serum tryptase level when they are perfectly healthy and not having a reaction. Then, crucially, they need to draw the patient's blood again within 1 to 2 hours of the onset of an acute attack.
So if the patient collapses, their blood pressure tanks, and they are rushed to the ER, the doctor draws blood. If the tryptase levels are totally normal and match the baseline, the doctor knows the mast cells weren't involved. The alarm went off, but there's no footprint.
Exactly. It must have been a cardiogenic shock or a severe panic attack.
But if the tryptase in the acute blood draw spikes significantly above that baseline,
then the doctor has concrete, irrefutable chemical proof that the mast cells degranulated. It is the smoking gun. It proves the immune system fired the weapon and caused the crash, even if, at the end of the day, we still have absolutely no idea what pulled the trigger.
And with that clinical reality established, the sheer exhausting burden of proving to the medical establishment that your body is betraying you for absolutely no reason, we need to pivot.
Yeah, we have to look at the human element.
Exactly. Because this deep dive cannot just be about the biology and the diagnostic flowcharts. We have to ask, what does it actually feel like to live inside a body that might turn on you at any second without a trigger you can avoid?
This brings us to the qualitative study in our source material, which is, frankly, vital to understanding this disease. For nearly half a century, the medical community has focused almost exclusively on the cellular mechanisms, the histamine, the tryptase, the blood pressure.
Just the numbers.
Right. They largely ignored the immense psychological toll of the condition. This qualitative study addresses that blind spot by interviewing 14 adult patients living with idiopathic anaphylaxis.
The researchers used something called the theory of unpleasant symptoms, or the 2US framework, to analyze these interviews. What exactly is that?
The 2S framework is a highly respected model in nerving research. It views a patient's experience through 3 interconnected lenses. First, it looks at the symptoms themselves, the intensity, timing, and distress.
Okay.
Second, it looks at influencing factors, which can be physiological, psychological, or situational. And third, it looks at the resulting impact on a person's cognition and their daily functional performance.
It seems like a very holistic way to look at illness. It doesn't just say you have hives. It asks, how does the unpredictability of those hives ruin your ability to focus at work?
Exactly. It acknowledges that a symptom is a multidimensional event. The unpredictable nature of IA creates intense psychological distress, which in turn can physically compromise the patient's resilience, creating a brutal feedback loop.
And the themes that emerge from these interviews are genuinely harrowing. The first major findings focus on the loss of control, profound confusion, and absolute raw fear.
The fear is visceral.
The researchers asked patients to describe the onset of their episodes, and the quotes are striking. Think back to the scenarios we opened with. These patients were experiencing sudden, violent physiological crashes while doing incredibly mundane things. One patient described being at a concert, just dancing with friends. Another was literally just walking down the sidewalk to the grocery store.
The sheer suddenness is what drives the trauma. If a patient has a severe peanut allergy, they know the boundaries of their safety. They read food labels obsessively. They interrogate waiters at restaurants. They exert a massive amount of control over their environment to stay safe.
Right.
But with idiopathic anaphylaxis, that locus of control is entirely stripped away.
Yeah.
There's no label to read. The environment is always potentially lethal.
One participant in the study described the feeling of the attack by saying, I almost felt like I was leaving, like I maybe was dying, to be honest. It was like I was going, but I was slowly going.
That's John.
Another patient described the brain fog and oxygen drop as feeling like they were a machine powering down. And one participant just bluntly stated to the researchers, I thought I was dead.
When we apply the 2S framework to analyze the psychology here, we see the anatomy of profound trauma. It is not just the acute physical fear of death in the moment. It is the subsequent destruction of the patient's identity.
Their identity.
Yes, every human being builds their life around certain routines, assumptions, and coping mechanisms. When any routine, eating, walking, sitting on a couch, can suddenly result in a near-death experience, those assumptions are shattered.
The study notes that this leads to an intense period of denial followed by a very real grieving process.
Yes, grieving for the life, the freedom, and the peace of mind they formerly had. One patient explicitly told the researchers, "I resent the things that it made me lose and the things I've missed out on as a result of it." It's a mourning process for their own healthy body.
Which leads directly into the next major finding from the study: the reality of living on alert or chronic hypervigilance. You survived the anaphylactic episode, but the mental health fallout is immense and permanent.
It never really stops.
Patients described their daily existence as walking on eggshells. One patient used the exact phrase that they feel like a ticking time bomb.
It's a state of constant, exhausting cognitive load. The study highlights a direct, proven relationship between atopic disorders, meaning severe allergic conditions, and long-term mental health struggles, particularly anxiety and depression.
Imagine living like this. You walk into a new restaurant or friend's house, or you step into a conference room for a meeting at work. Instead of looking at the decor or greeting your colleagues or looking at the menu, your brain is instantly obsessively scanning the room for threats. Where are the exits? If my mast cells degranulate right now and I collapse on this carpet, can EMTs get a stretcher through that doorway? Do any of the people sitting at this table know how to administer an EpiPen? You are constantly calculating your own rescue. You can never, ever truly relax.
And that level of chronic stress actually exacerbates the physical condition, which we will touch on when we discuss the biology of stress later. But beyond the internal anxiety, the social impact on these patients is equally devastating.
The sheer guilt these patients carry is heartbreaking. There is a specific anecdote from the study that really stayed with me. A patient had a spontaneous idiopathic anaphylaxis episode while attending her best friend's wedding. She survived, she was treated, but she told the researchers she felt like she had completely destroyed her day, the bride's day. These patients feel like massive burdens to the people they love most.
They are forced to witness the secondary trauma their illness inflicts on bystanders. When a severe anaphylactic episode hits, it is visually horrifying. One patient noted the sheer look of terror on the faces of their friends and family members.
I can't imagine watching someone go through that.
Unless someone is a medically trained professional or has been through this specific ordeal before, watching a loved one suddenly gasp for air, turn red, and collapse is deeply traumatizing. The patient carries the physical burden, but also the emotional weight of terrorizing their family.
Which brings us to perhaps the most infuriating part of this deep dive. Because when that biological alarm goes off and the patient is terrified and the family is traumatized, the hospital is supposed to be the safe haven. The ER is where you go to find salvation and clarity.
Ideally, yes.
But for IA patients, the medical system itself is often a source of profound secondary trauma.
The qualitative study delves heavily into negative experiences with healthcare providers. It is a recurring nightmare for these patients. And to understand why this systemic failure happens, we have to look objectively at how idiopathic anaphylaxis physically presents in the ER, which is often very atypical.
Right, because when I say anaphylaxis, most people picture the textbook movie version, the stereotypical trifecta. The patient's airway rapidly swells shut, their blood pressure plummets to dangerous levels, and their skin is entirely covered in giant raised red hives.
That is the classic presentation, driven by mast cells degranulating near the skin and mucosal tissues. But many IA patients do not present with all three of those classic symptoms simultaneously.
Oh, really?
Yeah, a patient might experience a massive drop in blood pressure, leading to syncope, alongside severe gastrointestinal cramping and vomiting.
Yeah.
But they have absolutely no hives on their skin. Or their throat might feel incredibly tight, but they don't have the skin flushing.
Because they don't look like the textbook picture of a peanut allergy, and crucially because they cannot point to a trigger and say, "I ate shellfish," the emergency room staff frequently misdiagnoses the physical event.
Often as a severe panic attack or a somatic symptom response.
The anecdotes and the sources regarding this are genuinely hard to read. There was a story of a patient who was at work when an episode hit. They were sitting on the floor, covered in hives, their throat tightening, experiencing exactly what happens during mast cell degranulation, and their boss forbade their coworkers from calling an ambulance.
Unbelievable.
The boss told the patient to just walk or drive themselves to an urgent care clinic.
The lack of situational understanding from laypeople is incredibly dangerous. But when that same dismissiveness happens within the walls of a hospital, it is catastrophic. The study detailed a truly shocking story of a patient who arrived at the hospital in active anaphylaxis. A hospital consultant came down to see them, a specialist who hadn't even seen this patient in a decade, and upon hearing it was idiopathic, this doctor completely discontinued all active treatment.
Yes. The quote from the patient was that the doctor just watched because she wanted to see what happened. She actively withheld a second EpiPen that the patient needed. She withheld a nebulizer treatment that the patient desperately needed to pull air into their lungs.
It's medically negligent, frankly.
She moved the patient into the intensive care unit, a place where the patient already had severe PTSD from a previous traumatic intubation, simply to observe the natural course of the reaction without intervention. It completely, totally re-traumatized the patient. And another patient in the study was told point blank by an ER consultant that the reaction they were having was in her head.
The fallout from this kind of medical gaslighting is severe provider mistrust. These patients are dealing with an incredibly volatile, life-threatening illness, yet they become so deeply distrustful of the medical establishment that they actively refuse to seek care.
One quote from the study really drove the horror of this home. The patients said they would only go back to the emergency room if they were probably in the process of dying or unconscious. Think about how badly a system has to fail you for your survival strategy to be, I will actively avoid the emergency room until I literally pass out on the floor. I honestly get fired up reading this. Why is the medical community so uneducated on this? How can an ER doctor look at someone struggling to breathe and just confidently declare it's stress?
It is undoubtedly a systemic failure, and the frustration is entirely justified. But if we analyze it objectively from the provider's perspective, we can see exactly where the breakdown occurs.
Okay, let's hear it.
Emergency departments are high-stress environments that operate heavily on algorithms and pattern recognition. Anaphylaxis is a fast-moving, incredibly chaotic emergency. ER doctors are trained to look for specific visual cues, the hives, the facial swelling.
They need a neat box to check.
Exactly. When a patient presents in shock, without those classic visual cues, and says, I didn't eat anything unusual, I didn't take any new medication, I don't know why this is happening, the standard medical algorithm breaks down. The doctor's differential diagnosis immediately shifts toward acute cardiac issues, or, lacking evidence for that, acute psychiatric distress.
So it's just an algorithm problem.
It highlights a massive, urgent need for advanced, specialized allergy education among frontline emergency workers. They need to be taught that anaphylaxis is a spectrum of symptoms, not a rigid three-point checklist.
Okay, so if the frontline ER struggles to recognize and treat the acute episodes when they happen, how do allergists try to prevent them from happening in the first place? How do you stop an attack when you don't know what the trigger is?
Right.
This brings us to a massive shift in how science is viewing this condition, because researchers are looking much deeper, down to the cellular and genetic level, to figure out if idiopathic is actually just a perfect storm of tiny, invisible factors.
This is where the science gets truly fascinating, and where the idiopathic label starts to peel away. The current leading theory in the literature is not that these immune events happen for absolutely zero reason. Rather, they happen due to a phenomenon called the summation of cofactors.
I love this concept. Explain what a cofactor is in the context of allergies.
A cofactor is an element that is not an allergen itself. If you're exposed to a cofactor, it will not cause an allergic reaction on its own. However, its presence in your body lowers the threshold for mast cell activation.
It makes them more sensitive.
Exactly. It makes the mast cell more unstable, more irritable, more twitchy. The theory is that idiopathic anaphylaxis is rarely caused by one single, massive, invisible trigger. It is a stack of these non-allergic factors silently piling up until the mast cell simply cannot hold its chemical mediators in any longer.
I picture the mast cells in these patients like a game of Jenga. You have this tall, relatively stable tower. If you remove one block from the bottom, say you have a really stressful week at work, the tower doesn't fall. It's totally fine.
Right. You can handle one block.
If you remove 2 blocks, you're stressed, and you take an Advil for a headache. The tower gets a little wobbly, but it's still standing. But then you add a third factor. You go for a brisk walk in the summer heat, you pull that third block, and boom, the whole tower crashes to the table.
And that crash is the anaphylactic shock.
None of those 3 things alone caused it, but the summation of them broke the system.
That is a brilliant way to conceptualize the summation theory. And the source materials deep dive into the specific biological mechanisms of these blocks, these cofactors. Let's look at NSAIDs like ibuprofen, naproxen, or aspirin.
Okay.
How do they make the immune tower wobbly? NSAIDs work by inhibiting an enzyme in your body called COX, or cyclooxygenase. This is great for stopping pain and reducing inflammation in a swollen joint. But inhibiting COX also systematically reduces the body's production of a molecule called prostaglandin E2, or PGE2.
And PGE2 is actually the good guy in this specific scenario, right?
Yes. Under normal, healthy circumstances, PGE2 binds to specific receptors on the surface of the mast cell. It acts as a stabilizing force. It's like a molecular glue keeping the cell's membrane intact and preventing the internal calcium levels from spiking.
I see.
When you take an NSAID, you reduce the PGE2, you remove the molecular glue, and the mast cell becomes primed to explode if anything else agitates it.
So taking an Advil for a headache secretly lowers your immune system's threshold. That is a massive block pulled from the Jenga tower. What about stress? Because we noted earlier that patients in the ER are told all the time it's just stress in a dismissive way. But stress actually has a very real, measurable biological mechanism here.
It absolutely does, and it proves the mind-body connection on a cellular level. Psychological stress, as well as severe physical fatigue, causes your central and peripheral nervous systems to release specific stress compounds, most notably corticotropin-releasing hormone, or CRH, and a neuropeptide called substance P.
And these aren't just floating in the brain making you feel anxious.
No, they travel throughout the body. And crucially, mast cells have receptors on their surface, specifically for CRH and substance P. These stress peptides physically bind to the mast cells. When they bind, they directly lower the activation threshold, making the cell highly reactive. It is a direct, undeniable biological link between the mind's psychological stress and the immune system's hair trigger response.
The fact that the mind-body connection is literally just substance P binding to a mast cell membrane is incredible. It validates every patient who felt their anxiety was making their physical illness worse. And the sources list other cofactors too, right? Things that pull more blocks from the tower.
Yes. Alcohol consumption is a known cofactor. Extreme changes in temperature, particularly heat, rigorous exercise, acute underlying viral or bacterial infections, and even severe disruptions in your circadian rhythm. Things like extreme jet lag or working rotating night shifts.
Wow, so many things.
All of these physiological stressors alter the chemical environment around the mast cell. If enough of them happen at the same time, the summation causes spontaneous degranulation.
But the summation of cofactors acting on normal mast cells is only half of the cutting-edge science in the update source. What if the problem isn't the environment acting on the mast cell? What if the mast cells themselves are fundamentally genetically broken from the very start?
This brings us into the realm of clonal mast cell disorders. This is where the medical field is aggressively unmasking the idiopathic label through advanced genetics and bone marrow pathology.
Let's talk about the genetic mutations. This feels like the frontier of allergy research.
It is. We have to start by looking at a condition called mastocytosis. This is a rare disorder characterized by the clonal expansion and massive accumulation of mast cells in the body's tissues. Essentially, a genetic error causes your body to overproduce them.
Okay, so just way too many cells.
Right. In children, it usually presents as cutaneous mastocytosis, meaning the extra mast cells cluster in the skin, causing distinct hive-like lesions. But in adults, it frequently presents as systemic mastocytosis, where the cells infiltrate the bone marrow, liver, and intestines.
And how do they actually diagnose systemic mastocytosis? Because the diagnostic criteria outlined in the sources are incredibly rigid and invasive.
They are very rigid. To definitively diagnose systemic mastocytosis, doctors often need to perform a bone marrow biopsy. They're looking for major and minor criteria. The major criterion is finding dense, clustered infiltrates of mast cells, specifically finding more than 15 mast cells aggregated together in the bone marrow tissue.
That sounds like looking for a very specific cluster of weeds in a massive lawn. What are the minor criteria?
They look at the physical shape of the cells under a microscope. In mastocytosis, the cells often have a spindled, abnormal morphology instead of their normal round shape. The most crucial minor criterion is identifying specific genetic mutations, most notably the c-kite mutation.
C-kite, what does that do?
The c-kite gene provides instructions for making a protein that controls mast cell growth. In mastocytosis, this gene mutates, essentially leaving the on switch for mast cell production stuck in the upward active position. The body just keeps making them.
So that is mastocytosis. Too many mast cells, they look weird under a microscope, and there's a c-kit mutation. But what about MSACS? Mast Cell Activation Syndrome. I've been hearing that acronym thrown around a lot more frequently lately in medical discussions.
MSACS is a different clinical entity, and it's critical to distinguish the two. With MSACS, the patient have a perfectly normal, healthy number of mast cells. And if you look at them under a microscope, they have a normal, round morphology. There is usually no c-kit mutation found.
But they're still having issues.
Yes. Functionally, they are deeply defective, they are hyperactivated, they degranulate and release their mediators far too easily in response to normal physiological or pathological conditions.
So if mastocytosis is having an army of millions of extra mutated soldiers, MCES is having a normal-sized army, but every single soldier is incredibly jumpy and has a hair trigger on their weapon. How do you diagnose that if the bone marrow looks normal?
The diagnosis for MCS relies on a clinical triad. First, severe, recurrent, episodic symptoms of mast cell activation across multiple organ systems. Second, a documented significant spike in serum tryptase during an acute episode, proving the mast cells are firing.
Right, the tryptase footprint.
And third, a positive, measurable clinical response to medications that specifically target and stabilize mast cells or block their mediators.
And then there is the newest, perhaps most fascinating genetic discovery mentioned in the update source, a condition called hereditary alpha-tryptasemia, or HAT.
Yes, HAT is an autosomal dominant genetic trait that is revolutionizing how we view unexplained anaphylaxis. It is caused by a structural variation in a specific gene called the TPSAB1 gene. This is the gene responsible for encoding the enzyme tryptase that we talked about earlier.
And what goes wrong with the gene in these patients?
They simply have extra copies of it. While most people have a standard number of copies, patients with HAT have gene duplications or even triplications. Because they have extra copies of the instruction manual for making tryptase, their baseline serum tryptase level, even when they are perfectly healthy and not reacting, is constantly abnormally elevated, specifically above 8.0 nanograms per milliliter.
Wow.
And recent cutting-edge research is showing that HAT is highly prevalent in patient populations suffering from severe, unexplained idiopathic anaphylaxis. The extra tryptase fundamentally alters how reactive the immune system is.
If we connect this to the bigger picture, understanding these genetics is monumental for the patient experience. Think about the people from the qualitative study. The patients who were explicitly told by doctors that they were crazy, that it was just a panic attack, that it was entirely in their head. Now, a doctor can draw their blood, look at their DNA, count the exact copies of the TPSAB1 gene and say, you aren't crazy. You have hereditary alpha-tryptasemia. Your literal DNA is coding for this hyperreactivity. It finally gives concrete, undeniable biological answers to people who have been gaslit by the medical system for years.
The profound validation that comes with a genetic diagnosis cannot be overstated. It completely shifts the burden of proof off of the patient's psychology and places it firmly onto their biology, where it belonged all along.
So, armed with an understanding of these cofactors, the Jenga tower and the complex physiological mechanisms, we arrive at the final crucial question of this deep dive. How do patients actually manage this disease day to day and reclaim their lives? How do you effectively treat a condition when you don't definitively know the trigger?
The absolute foundation of management, the golden rule that every single piece of medical literature agrees upon, is acute non-pharmacologic management. Every single patient diagnosed with idiopathic anaphylaxis must carry an epinephrine autoinjector like an EpiPen or a similar device at all times. Everywhere they go, every single day, regardless of how well they feel or how effective their daily preventative medications seem to be.
Right. Epinephrine is the ultimate override switch. How does it actually stop the crash?
Epinephrine is synthetic adrenaline. When injected into the thigh muscle, it acts immediately as an alpha and beta adrenergic receptor agonist.
Which means?
It forcefully constricts the dangerously dilated blood vessels, which instantly spikes the plummeting blood pressure back up to a survivable level. Simultaneously, it relaxes the smooth muscles in the airways, opening the lungs back up so the patient can breathe. It is the only drug in the world that can rapidly reverse the cardiovascular and respiratory collapse of anaphylaxis.
So the EpiPen is for when the tower falls. But beyond carrying the rescue pen, patients manage the condition by rigorously trying to prevent the tower from getting wobbly in the first place, right?
Exactly. They engage in strict avoidance of known cofactors. They might practice intense psychological stress management to keep CRH levels low. They avoid NSAIDs like ibuprofen entirely if they notice a sensitivity. They modify their exercise routines to keep their core body temperature down.
It's just managing all those little blocks.
And they aggressively treat any underlying conditions like asthma, which can make a respiratory reaction infinitely more dangerous if an attack does occur.
But they can't just live in a protective bubble forever. They need prophylactic treatments, the daily medical toolkit to stop the mast cells from reacting in the first place. What does the daily pill box look like for a patient with IA?
The first line of defense usually starts with a heavy regimen of oral agents. doctors will prescribe high, often off-label doses of second-generation H1 antihistamines like cetirizine or fexofenadine. But they combine those with H2 antagonists like famotidine.
Why both H1 and H2?
Because histamine binds to different receptors throughout the body. H1 receptors are heavily involved in the skin and airways, causing hives and wheezing. H2 receptors are prominent in the gastrointestinal tract and blood vessels. You have to block both pathways to build a comprehensive shield.
That makes sense.
They also frequently prescribe leukotriene receptor antagonists like montelukast, which block a completely different inflammatory chemical mediator released by mast cells. The strategy is essentially throwing a chemical net over the mast cell to catch and neutralize any mediators if the cell starts to leak.
But what happens when the oral pills aren't enough? Because for many patients with severe IA, antihistamines are like bringing a water pistol to a house fire. If the pills fail, the sources say they move up to the big guns, biologics, specifically a drug called omalizumab. And this is where the medical literature presents a really fascinating, almost baffling contradiction.
It is a classic frustrating example of real-world clinical experience directly clashing with the results of randomized trials. Let's look at the mechanism first. Omalizumab is a monoclonal antibody. When injected, it circulates in the blood and binds directly to free IgE antibodies. The antibody is typically responsible for classic allergies like pollen or peanuts. It neutralizes them before they can attach to the mast cell.
But wait, we established that idiopathic anaphylaxis isn't supposed to be an IgE-mediated allergy because there's no known allergen triggering an IgE response. So why would they use an anti-IgE drug?
That is the paradox. Theoretically, it shouldn't be the primary solution. Yet, incredibly, many published case reports and retrospective studies show that omalizumab works absolute miracles for IA patients.
Wow.
The standard protocol in these successful reports is a 300 milligram dose injected subcutaneously every 4 weeks. Patients who are suffering from debilitating weekly anaphylactic episodes suddenly go into complete sustained remission.
Right. The case studies absolutely rave about it. It gives people their lives back. But
when researchers finally secured the funding to conduct a rigorous, randomized, double-blind, placebo-controlled study on omalizumab, specifically for idiopathic anaphylaxis, the results were incredibly underwhelming.
how underwhelming.
The study showed that the biologic was only slightly more effective than a placebo saline injection, and the difference didn't even reach statistical significance.
How is that even possible? How do allergists watch this drug work miracles in their clinics every day, but it completely fails the gold standard test of scientific efficacy?
It likely points back to the fundamental flaw of the idiopathic label itself. Idiopathic anaphylaxis is not one single unified disease. It is a heterogeneous umbrella term covering several undiscovered mechanisms. For a specific subset of patients whose IA involves some deeply hidden, unrecognized IgE pathway, omalizumab is a miracle drug.
Ah, I see.
But for the patients in the trial whose IA was actually driven by a hidden c-KIT mutation, or HEE, or purely by non-IgE cofactors, neutralizing IgE does absolutely nothing. The drug is highly effective, just not for everyone hiding under that massive umbrella.
The sources also mentioned dupilumab, another biologic that targets different immune pathways, as a newer alternative showing promise. But if the biologics fail or a patient's insurance denies them, they have to look at advanced, often risky options for refractory cases.
Yes. Doctors can use systemic corticosteroids, like prednisone, to aggressively suppress the entire immune system. But the clinical guidelines strongly warn against prolonged use. The side effects of chronic steroid use, severe bone density loss, drug-induced diabetes, weight gain, and systemic immune suppression are brutal and often outweigh the benefits.
That's a steep price to pay.
In the absolute most extreme, uncontrollable cases, hematologists might use a heavy immunosuppressant called rituximab to deplete certain immune cells entirely.
But running through this entire gauntlet of treatments, the EpiPens, the massive doses of antihistamines, the biologics, the steroids, the real path to taking back control always loops back to the human element. Managing the biology is only half the battle. Theme 5 of our qualitative study focuses on the journey towards support and affirmation.
The medical toolkit is essential for keeping the patient's heart beating, but the psychological toolkit is what allows a patient to actually survive the emotional journey. The qualitative study extensively highlights the absolute, overwhelming relief these patients feel when they finally find a doctor who doesn't dismiss them.
It must feel amazing.
Finding a physician who listens, who validates their terrifying experience, and who truly understands the nuances of mast cell disorders, is often cited as the major turning point in their mental health.
There was a specific story in the qualitative study about community support that I found absolutely beautiful, and it contrasts so sharply with the trauma we discussed earlier. One patient was talking about their friend. This friend knew that the patient had to wear a medical alert bracelet every single day just in case they collapsed in public and couldn't speak. Usually, these bracelets are sterile, ugly, clinical pieces of metal. So the friend went out and bought the patient multiple anaphylaxis medical alert bracelets in all different styles, colors, and materials, so the patient could match them to any outfit they wore.
It seems like a minor detail, but psychologically, it is a profound act of solidarity.
Exactly. It completely combats that loss of identity we discussed in Theme 1. It is a friend saying, I see your illness, I recognize your need for safety, I am not afraid of it, and I want you to still feel like yourself. It's an affirmation of their humanity beyond their broken immune system.
And that kind of support is what fuels perseverance. It allows patients to shift from a mindset of purely surviving to a mindset of actively living.
I want to read a final, defiant quote from one of the patients in the qualitative study. After going through all the trauma, the unpredictable near-death experiences, the ER gaslighting, the constant, exhausting hypervigilance, they told the researcher, I could die tomorrow or I could make it to 90, so just live life in the meantime. I am not being taken down by anaphylaxis.
That is the ultimate goal of managing any severe, unpredictable chronic illness. Not just preventing the physiological reaction, but restoring the patient's agency. It is about helping them find the will to live fully and boldly despite the ever-present uncertainty.
What an incredible, harrowing journey. To recap what we've unpacked today in this deep dive, we started with a terrifying biological mystery, an invisible threat that sends the body's alarm system into a lethal panic for no discernible reason. We explored the exhausting diagnostic labyrinth, the massive differential diagnosis playing guess who with rare neuroendocrine tumors and delayed tick bites.
We really covered a lot of ground.
We sat with the profound psychological trauma of living as a ticking time bomb and the tragic reality of medical gaslighting when clinical algorithms fail in the emergency room. But we also looked at the hopeful cutting edge of science. The summation of cofactors, the Jenga tower of stress hormones and NSAIDs, the advanced genetics of mutated mast cells and extra TPSAB1 genes. And ultimately, we saw the sheer resilience of the human spirit fighting to take back control.
It is a remarkably comprehensive look at a condition that exists at the very edge of our current medical understanding. And synthesizing all of this leaves me with a final thought-provoking extrapolation based on the clinical trends in the source text.
Oh, lay it on us.
We noted earlier that the diagnosis rate of idiopathic anaphylaxis has already dropped from 59% down to 35% simply because of scientific advancements. We are finding the hidden triggers. It begs a fascinating question. Are we looking at a disease label that will eventually cease to exist entirely?
Oh, wow.
As we continue to map the human genome with greater precision, as we unlock the deepest secrets of genes like TPSAB1 and CKI, and as we discover more hidden environmental allergens like alpha-gal, perhaps 50 years from now, the word idiopathic will be completely removed from the allergy dictionary. Perhaps one day our diagnostic tools will be so sharp that every single patient will finally know the true name of their invisible enemy.
That is an incredible thought to end on. To imagine a future where the body's alarm never goes off without us knowing exactly who broke in and exactly how to stop them. Imagine the peace of mind that would give millions of people. Thank you for joining us on this deep dive. I hope it gave you a whole new perspective on the complex machinery of your immune system, the heavy weight of invisible illnesses, and the incredible, relentless science working every day to solve these biological mysteries. Keep that curiosity alive, always ask questions, and most importantly, remember to relentlessly advocate for yourself in the doctor's office, because your experience is real and your symptoms are valid, even if the trigger is still hiding in the shadows. Until next time.